All right, here we go. Recording.
All right. Welcome to the Fundamentals of Sports Medicine Cervical Spine Lecture 101. Today's lecture was created by and large by our contributor and partner, Adam McCawy, who's on the call tonight as well. However, it's going to be presented by Ken and myself tonight. We're going to go through the anatomy, physical exam, and basics of X-ray interpretation for cervical spine. And of course, as usual, Fundamentals of Sports Medicine has no disclosures, financial or otherwise, to disclose at this time. If you haven't already followed us on our social media accounts, please do it. Twitter, Instagram, Facebook are all good ways of getting at us. And if you're not on the email list for some reason, email us at fundamentalsofsm@gmail.com.
All right, guys. So we'll go over imaging. So whenever you have any type of neck pain, you're going to order cervical X-ray series, which is composed of the AP anterior posterior view, lateral, and odontoid view. You could add more other views like oblique or flexion and extension, but we're just going to go over these three. These are the main three you're going to encounter. So AP anterior posterior, we're going to start with alignment. First, we're going to look at the lateral edges of the C-spine. They need to be nice and aligned here and right here. And you have to make sure the spinous process is aligned. So annotate just a little bit. So C-spine, that's a nice curve and aligned. And spinous process are aligned. Next, we're going to identify the bony structures here. I identify T1. That way it makes me know where C7 and everything else is. So T1 is right here. The reason I know that this is T1 is because the lateral transverse process are pointing superiorly. So transverse process pointing superiorly, and the first rib is coming off T1. Versus C7, the transverse process is pointing inferiorly, and there's no rib. So 7, 6, 5, 4, 3, 2. That's 2 here. Do you see? That's the atlas, and then the axis is right here. Okay. I trace every single vertebrae just to make sure there's no fracture, there's no compression fracture or any other type of burst fracture that might be present. I also look at the uncinate process here. Are these protrusions right here? Those protrusions help articulate with the vertebrae above, and that's also known as the joint of Luschka, and that's a joint. Yeah, anatomy, huh? Back to medical school. I also look in between each vertebrae here. There's no actual definitive like measurement. If I measure this, there's definitely some decreased space. Just kind of eyeball it just to make sure there's no gross decreased space, but just make sure that there's space in between each vertebrae. And every vertebrae has a disc in between. And that's pretty much it as far as the bones here. And we went over the disc space. Now we're going to go over the soft tissue. Soft tissue here. You look on the lateral side to make sure there's no masses there. You look here at this darkened shadow here, which is the trachea. Make sure it's midline. And you look at the apices of the lung, which is right here and right here, just to make sure there's no masses in there, no consolidations, and you look at the lung markings going up. Any questions, Max?
No, I think it's just a really good point that whenever you get an X-ray of bony anatomy, you want to make sure that you're not ignoring the soft tissue or other structures that you might incidentally catch. I think everybody begins to have a story about how they've caught some pathology, I think usually cancer, from a more careful, methodical read of a whole X-ray. One of my instructors several years ago found a Pancoast tumor, I think, looking at a neck X-ray, by the way.
So just make sure you look at the whole structures and kind of give you like a systematic approach of how to go through it. But you know, to each their own, whatever works for you. So we're gonna go over the lateral X-ray here. I want to point out here that the vertebrae are not straight up and down. They kind of have like a curvature. They have a normal lordotic curvature. If you guys can appreciate this, it kind of has like a curvature. And first I want to start with the alignment, and there are 4 alignment lines. You know, let me just draw this for you guys here. So first is the AVL, which is the anterior vertebral line. Sorry, it's a little curved towards the bottom, but it's not going to be straight up and down. It's going to have a normal lordotic curvature. And that's the anterior longitudinal ligament. And then this is the vertebral body. Most posterior aspect of the vertebral body is the posterior vertebral line, and that's the PLL. And the next line is the spinal laminar line, and that's this line right here. Sorry, that's really bad drawing there. And then the last line is the posterior spinous line, which is this line right here. And maybe you guys might pose the question, how was I able to determine the spinal laminar line? So I want to go to this vertebrae here in the bottom left here, and just kind of to orient ourselves of where we are here: anterior, posterior, vertebral body, transverse process, pedicle, articular or lateral masses, lamina, and I'm sorry if you hear the dog in the background, and the spinous process. So if you see here, lamina, spinous process, when these guys connect, it becomes really thick here. And that thick portion here is this really evident line here. So that's the spinal laminar line. So we draw the line straight down through here. That's the spinal laminar line. So lamina, spinal laminar line, spinous process. Let's identify the bony structures here. We're gonna go from anterior to posterior, from left to right. And this here is a vertebrae here, a vertebral body. Transverse process is kind of U-shaped structure here. It's not really too well defined, but if you see kind of like a U shape, that's the transverse process there. Next, we'll go on to the pedicles, and the pedicles are just this small little portion right here. It's really, really subtle. Here, you could really determine here, if I draw it for you guys right here. That's it, that's the pedicle. So vertebral body, pedicle, and then next is the lateral masses, and these are the lateral masses. Sorry, I kind of drove over the pedicle a little bit, but that's the lateral mass. And the lateral mass articulates with the vertebrae above and below. And so lateral mass here, and then the lamina, it's right here. And then the spinous process is right here. And I'm sorry if you hear my son in the background. I also want to point out here that to determine if this is a good X-ray, you need to be able to see C7 and T1. So how do I know what's what here? All right, so this here is the dens. So this must be the axis, and this is the anterior process. Sorry, this is the posterior process. Oh, sorry, arch, anterior arch, posterior arch. So this is C1, atlas, C2, axis, C3, C4, C5, C6, C7, and we can't see T1. So in theory, this is not a good enough X-ray, And the way we actually get T1, we can order a swimmer's view in which we put an arm up above the head. That brings the most anterior the shoulder down, exposing T1. All right, we'll move on. Sorry, I think it's important to make sure that you need to be able to see T1. It's really important to have that. Next, we'll look into cartilage and spaces here. The most important space that we care about, let me erase this, is the atlantodental interval. And atlantodental interval is, remember, this is the dens. This is the most anterior arch. And this interval here is what we care. And that interval should be about 3 millimeters. Some books have it as 3.5, but if it's grossly abnormal, then you would know that there's something wrong with the transverse ligament. And then you should probably get advanced imaging.
Do you mind just saying the reason for that, Ken?
Because you're going to have atlantoaxial disruption. Is that what you're asking?
Yeah, that essentially that if you see a space greater than that, were you about to get to this, by the way? I didn't want to preempt you.
Yeah, I have another picture after this. Yeah.
Sorry.
Always stealing my thunder.
I was ready for it. As if I don't have access to the slides before.
I know, right? So next we'll go over the disc spaces. So again, there's no exact measurement, like 3 millimeters here. There's no exact measurement. Just kind of look at it, make sure it's no grossly abnormal. There's actually space in between each one. You also have to look at the space in between the masses here. So make sure the space here. And just to clarify, this is the atlantodental interval, also known as the predental space. Next, we'll go into soft tissue. Make sure there's nothing in the back, no lateral masses. So this here is the nasopharynx, oropharynx, pharynx, glottis, hyoid bone, and the trachea. And one of the most important spaces that we have to take into account is called the prevertebral space, which is this gray space here. I can outline it for you guys here. You guys hear that music in the background? Just FYI, no?
It's very faint.
Okay, okay.
It's not bothersome.
Okay, sorry, I apologize. That's my son's music too. So this space here is what's really, really important. So let's find C4. So this is 7, 6, 5, 4. Like around 4 is where you have the change in space here. So anything above 4 should be around 6 to 7 millimeters. So this space here should be around 6 to 7 millimeters. The space here should be about 2 to 2.2 centimeters. And why do we even care? Because retropharyngeal abscess could occur here. So if you get an X-ray, a lateral X-ray, you will see this space. Let me undo this real quick. So you would see this space here be just as thick. So it'll kind of go all the way up. So this would be gray as well, right? So that's why we even care about this retropharyngeal space or prevertebral tissue. And that's basically it for the lateral X-ray. Do you have anything to add, Max?
I just want to see if you wouldn't mind going over how you identify the odontoid process and the anterior arch of the atlas one more time, just so that everybody can really get that in their brains, because I think it's a dense part of the image.
Yeah.
If they don't have practice reading it, it can be a little tough, but I think it's interesting and it's relevant to be able to see it.
Definitely. So I'm not going to do it here. I'm going to do it in the next image because this is a crappy image here because you really can't tell the space here too well. So I put another image on the next slide here. And here you're able to tell here the dent a little bit better. Take here. So this is C1 here, C2. That's the dens. This here is the anterior arch. And the space is not really, you won't be able to tell, but look at this here, where these red arrows are. That's the space you want to measure. So that's what we're trying to identify. Some cervical x-rays, lateral x-rays, you can actually see that darkened space there, and you'll be able to measure it better, but sometimes you just can't. It just doesn't come out as a good picture. So that's why I put this image on the side here, more advanced imaging, in which you're able to determine here the space. So this here is the dens, the anterior arch, and that's the space in between. Yes, yes, definitely get a CT of the neck. Krishna, sorry, I apologize if I said that wrong. Everybody gets my last name messed up, so I apologize. Next here, I put these images here. One, to show you that this is actually a better image, the one to the left. So 1, 2, 3, 4, 5, 6, 7, and T1 looks better. So this is actually a better lateral x-ray. And the image here in the middle is a swimmer's x-ray, in which one of the arms is fully flexed, I guess, pointing up to the sky, and that exposes T1 better. But this image is actually doesn't point T1, but the one on the left shows it's a pretty good image here. The one on the right is kind of wanted to show more the ADI, the space here in between. So there's a question, do you ever evaluate neuroforamen on lateral, or do you need an oblique? Yeah, so that's a great question. There are many images for cervical x-ray. I kind of just wanted to go over the basics here. If you want to look at the neuroforamen, you need to order an oblique view, because that gives you the best view of the neuroforamen. So you are right in that aspect. Another thing I want to add is, when do you order flexion and extension x-ray? You want to order it. I guess I want to go back a little bit. When do you not want to order it? You want to order when you do not want to order if you suspect any type of instability in the neck, right? Because you're kind of stressing the ligaments. So if you're stressing the ligaments, you don't want to order a flexion extension, because you can make it worse. So lastly, here is the odontoid view, and you want to order it open mouth, because you're able to see C1 and C2 better. So let's go back and look at the bones here. Grab my marker here. C1, C2. C1, this lateral masses of C1. C2, dens, body. Next, you want to look at the space. So you want to look at the dense and lateral masses space, so the space in between here and here. Make sure they're symmetrical, make sure they're equal. If they're not symmetrical, it's likely that they probably turned their head. So you probably have to get a better imaging. You want to also look at the space in between the lateral masses, so the lateral masses of C1 and C2, make sure they're nice and equal and symmetrical. And that's basically it. Max, did you want to add anything to the odontoid view? Open mouth. Remember, order it open mouth.
No, that's good. I think if anybody's wondering, the white spaces, the white images that you're seeing on the teeth are fillings, by the way. Just in case anybody was wondering.
Thanks, Max.
You're welcome.
So here are our references, and we're going to get into some board-style questions. It'll be just a few questions.
I think it's just 3 tonight. We'll start off with how many cervical nerves and vertebrae are there? A, 7 nerves and 7 vertebrae. B, 7 nerves and 8 vertebrae. C, 8 nerves and 7 vertebrae. Or D, 8 nerves and 8 vertebrae.
Quick and easy. Go ahead and put your answer, please.
Ken, did we see this actually on a board exam at one point, by the way?
I think so. I think so.
Yeah, in case anybody wants to accuse us of putting in a question that's too simple, by the way.
Did you pick Emax?
No, I got that out of my system, man. I don't do that anymore.
All right.
No, I did.
All right, we'll end the poll. Share results.
Very
All right,
nice.
everybody pick C.
So good. This is again just a pure anatomy question. Just remembering that in the cervical spine, the nerve exits above the vertebrae with its namesake. So looking at the anywhere in the image, you can see that the numbers on the vertebrae correspond to the name that they are in the cervical chain, and that their nerve root exits above them. And if we focus in on C7, we can see that C7 has a cervical nerve root C7 and a C8, before T1 below it has the T1 nerve root exiting inferior to T1. And so therefore, for the rest of the vertebral column, you have the nerve exiting inferior to its name, which is why there are 8 cervical spinal nerves with only 7 vertebrae.
So C1 through C7 all exit above, except for C8. It's inferior.
I think yeah, the question was a test of my dyslexia as well on the exam. I think when I took it, it like kind of like wigged me out. It took me maybe the longest of any of the questions that I had to do. Okay, yeah. Question number 2. You are covering a local college football game when a player approaches you holding his left arm. He's complaining of a dead arm. He initially has trouble lifting his arm above his head, but after a few minutes, he mentions that he feels normal. You suspect a stinger and know that the most common nerve affected is the C5-C6 nerve. As part of your physical, what strength or strength test are you performing to check the integrity of the C5-C6 nerve?
Pick Emax.
I'm tempted.
All right, we'll end the poll here. Good job, guys.
Okay, nice. This again, I hope everyone did a little sort of dance to themselves to check this. But again, the emphasis on this question is for 2 things. One is, of course, just knowing the muscular innervation for the various muscles and movements of the arm with regards to the nerve roots, but also to remember that the C5 nerve root is going to be the most common nerve root affected by a stinger because of its superior location on the brachial plexus. It's the most likely to have an issue with distraction when pulled or in a tackle where somebody's likely to actually get a stinger. And so again, here we have a more detailed list of the innervation of the various muscles of the arm with their corresponding nerve roots. And I'll just do the dance one more time where we have C5, C5, C6, C7, C8 with finger flexion, and T1 with finger abduction.
You can even check finger like grip strength with that. So
What, T1 you're saying, grip strength?
no, for 8.
Oh yeah, that's true. It's a little tough that you want to like kind of get the claw hand to do
The rock climber hand.
yeah, C8. But no, you're right, of course. Last question for the evening. How do we do on time, by the way, tonight? Pretty good. A football player suffers a ruptured intervertebral disc in his neck. The disc compresses a spinal nerve exiting through the intervertebral foramen in his cervical vertebrae. The patient is complaining of pain that is radiating down to his shoulders and numbness and tingling in his thumb and index finger. What is the most likely nerve root that is affected? A, C4, B, C5, C, C6, D, C7, E, T1.
few more seconds and then we'll close it. You guys doing a great job paying attention. Like it. All right.
How'd we do? Oh, impressive stuff, guys. Nice job. So again, this is my other little dance of just knowing the sensory innervation of the arm once again, working our way down from the top. We've got C5 on the lateral shoulder, lateral arm, getting down into the elbow, and then moving across the hand, C6, C7, C8, and then finally to T1 on the medial arm, medial elbow. And so this guy with symptoms in the thumb and a little bit of the index finger, we're going to be looking at C6 most likely. I think we have just a little brief explanation in here. Again, this is just driving home the 7 cervical vertebrae, 8 pairs of cervical nerves, and radiculopathy, where you're seeing numbness should be able to be parsed out from its origin of what nerve root is most likely affected. Again, I think this is most helpful or clinically valuable on the sideline, but it's something that I think a physician ought to be able to get through in any event.